Hello and welcome to Personalized Endocrine Care, uncovering root causes of estrogen dominance. My name is Adair Anderson. I am the product marketing educator at Vibrant Wellness. I'm also a registered dietitian with a private practice called Eating with Integrity, where I resolve functional gut disorders like IBS. I earned an undergraduate degree in biochemistry, a master's degree in clinical nutrition from Bastyr University, and I've also completed advanced training in functional medicine through the Institute for Functional Medicine. Here's our agenda. First, we'll define estrogen dominance, discuss the symptoms associated with high levels of estrogen, and highlight the prevalence and impact of this condition. Then, I'll introduce my 3-pathway framework for identifying the root causes of estrogen dominance. We'll discuss the best ways to measure hormones. I'll introduce you to Vibrant's Hormone Zoomer test and an estrogen dominance case study. Then, we'll follow that case study through the 3-pathway framework using actual Hormone Zoomer results. Estrogen dominance is defined as a condition of increased estrogen levels relative to progesterone levels in the body. Additionally, many conditions are thought to be associated with or exacerbated by estrogen dominance, including breast and uterine cancers, fibroids, endometriosis, and polycystic ovarian syndrome. Symptoms of estrogen excess include breast tenderness, fibrocystic breast changes, which is a common benign condition characterized by lumps, cysts, or pain and tenderness in the breast, typically linked to hormonal fluctuations during the menstrual cycle. Also, mood swings, uterine fibroids, and heavy bleeding. Heavy bleeding includes menstrual periods that last for more than 7 days, periods that involve passing large clots, or require a tampon or pad after less than 2 hours, including needing to change pads or tampons during the night. Heavy menstrual bleeding is one of the most common problems women report to their healthcare provider. It affects more than 10 million American women each year. That means 1 out of every 5 women has it. Untreated, heavy or prolonged bleeding can stop women from living their life to the fullest. It can also cause anemia. Uterine fibroids are extremely common, affecting as many as 75% of women in the United States. In most cases, these small, non-cancerous tumors are harmless and do not require medical treatment. However, in some circumstances, uterine fibroids can grow quite large, leading to multiple issues. Even small fibroids can be problematic, though, depending on their location, and may lead to medical complications or fertility problems. In general, when uterine fibroids become too large, too numerous, or start pressing against another organ, a woman might experience severe pelvic pain or abdominal swelling, discomfort during sex, heavy menstrual bleeding, or problems with urinating or defecating. Also, anemia due to blood loss, and even infertility, miscarriages, and other pregnancy complications. So, now that we've defined estrogen dominance and discussed the symptoms, prevalence, and impact of this condition, let's dive into the root causes and how to identify it in your patients. Estrogen dominance may be the result of 3 things: overproduction of estrogen by the body, changes in estrogen metabolism and excretion, specifically impaired detoxification, or an imbalance in the estrogen to progesterone ratio, which for the purpose of this presentation I'm calling inadequate progesterone. So now that we've got an overview of the root causes of estrogen dominance, how do we measure it? Well, when measuring hormones, it's primarily a decision between serum, saliva, and urine. Here are the strengths and limitations of each. Serum hormone testing is the current standard of care for monitoring oral hormone replacement therapy, pellets, or patches. The strength of serum is that you can test thyroid hormones, sex hormone binding globulin, and sex steroids in one single blood draw. The downside of serum is that it's a one-time collection. In contrast, saliva and urine are generally collected at 4 points throughout the day, so it provides insight on diurnal rhythm. The biggest strength of testing hormones via saliva is that saliva measures free bioavailable hormone rather than total bound hormone. Also, it's best for monitoring topical HRT like creams and gels, since saliva is more representative of tissue levels of topical hormones than serum or urine. Additionally, it's well-researched for assessing adrenal and HPA function. The third hormone testing option is urine. A key strength of urine hormone testing is that it includes urine hormone metabolites, which can reflect metabolism and clearance of hormones, including liver detoxification pathways. Most importantly, urine hormones can accurately reflect baseline hormone levels in most patients. For the full list of strengths and limitations, please check out the serum, saliva, or urine handout shared below. In summary, there is no perfect test. All testing comes with strengths and limitations, of course. But what if there was a new testing option that provided even deeper hormonal insight? Turns out there is. Vibrance Hormone Zoomer is a urine test that combines evaluation of adrenal and sex hormones and metabolites, and that's including diurnal cortisone, cortisol, and melatonin, with endocrine disruptors, bone health markers, and an oxidative stress marker, all to help you identify root causes of hormone-related conditions like estrogen dominance. The Hormone Zoomer includes all the markers listed on this page. Starting with the table on the left, the Hormone Zoomer includes adrenal hormones and metabolites, hormone ratios, the 4-point diurnal cortisol, cortisone, melatonin, and creatinine, also the sex hormones, estrogen, progesterone, testosterone, and their metabolites. And then looking at the table on the right, the Hormone Zoomer also includes 13 endocrine disrupting chemicals, 2 bone health markers, and the oxidative stress marker 8-OHDG. Now, to help us better visualize the 3 root causes of estrogen dominance, we're going to follow a case study through the 3-pathway framework. Meet Kathy. Kathy is a 40-year-old female who is 5'7", weighs 150 pounds, making her BMI 23.5. She has a high-stress corporate job as a project manager, uses conventional beauty products, frequently drinks from plastic water bottles, and wears a plastic night guard every night. She does report poor sleep and eats a diet high in processed foods. She complains of heavy periods, breast tenderness, mood swings, weight gain, fatigue, and insomnia, and also reports increased stress levels and worsening PMS symptoms. So keeping Kathy in mind, let's dive back into the 3 root causes of estrogen dominance. The first cause of estrogen dominance is overproduction of estrogen. Great, but how can we quantify elevated estrogen production? Well, we can look at the patient's levels of estrone and estradiol. Let's take a look at Kathy's Hormone Zoomer results, specifically the sex hormones flowchart that helps visualize estrogen production. Starting in the upper left, we take cholesterol and turn it into pregnenolone, then to DHEA, and then androstenedione. Okay, looking at the black circle and arrow, we then use the aromatase enzyme to turn androstenedione into estrone, also known as E1. From there, we can convert E1 into E2, estradiol, and E2 into E3, estriol. Looking at the red circle and arrow, we can also use aromatase to turn testosterone into estrogen. As you can see, Kathy has elevated levels of E2. Her estradiol is 5.41, but normal levels fall between 0.84 and 1.82. And looking upstream, this appears to be the result of androgens being aromatized into estrogens. So, what impacts aromatase? Well, lots of things. Inflammation and hyperinsulinemia are at the top of the list. Insulin resistance results in increased estrogen levels both by increasing aromatase activity, resulting in the conversion of testosterone into estrogen, and also by decreasing sex hormone-binding globulin, resulting in higher amounts of free circulating estrogen. So does Kathy have either of these? Perhaps. She reports stress, mood swings, fatigue, and also eats a diet high in processed foods. This is a great opportunity to encourage her to transition to a nutrient-dense, whole foods-based eating plan. I'd probably start her with IFM's core food plan to promote balanced blood sugar throughout the day. I would also consider testing to investigate root causes of inflammation like food sensitivities, gut dysbiosis, toxins, or infections. Speaking of toxins, the endocrine disrupting chemical atrazine has also been shown to increase aromatase. Kathy's Hormone Zoomer results revealed that she does have high levels of this chemical, which tells me that Kathy needs some detox support. How about nutraceutical impact on aromatase? Well, white peony, licorice, rutin, forskolin, and quercetin can all increase aromatase activity. And it turns out that Kathy loves licorice tea. She was drinking it every day. However, after reviewing her Hormone Zoomer results, I had her take a break from licorice. So what decreases aromatase activity? Is there anything Kathy can do to slow conversion? In terms of foods, she can eat more white button mushrooms and legumes, especially soybeans, which are high in the isoflavone genistein. Genistein is known for its potential health benefits and its ability to act like an estrogen in the body. For those who may be wondering, will giving a phytoestrogen to a woman with symptoms of estrogen dominance make her symptoms worse? Great question, I'd love to tell you. Genistein is a selective estrogen receptor modulator, or SERM. This means it's weakly estrogenic at low estrogen levels, for example, during postmenopause, but anti-estrogenic at high endogenous estrogen levels, for example, estrogen excess situations like Kathy's, because it actually competes with stronger endogenous estrogens for receptor binding. Thus, in premenopausal women with high estradiol, genistein might actually have net anti-estrogenic effects at the receptor level, so it won't worsen symptoms. However, if you feel iffy about soy, you can also recommend parsley, celery, celeriac, and chamomile flowers, which are all high in apigenin. Or have her focus on getting more chrysin, which is a naturally occurring flavonoid found in plants including passion flower, honey, and propolis. So, in addition to starting on IFM's core food plan, Kathy also replaced her daily licorice tea with a lovely chamomile passion flower tea. As I mentioned before, I'd want to do testing to investigate inflammatory stressors for Kathy. In addition to the ones I already listed, I also asked Kathy about any chronic injuries or recent surgeries. She's pretty sedentary, so excess exercise isn't an issue for her, but it can be for some clients, so don't rule that out. On a related note, a great test to identify a patient's oxidative stress load is Vibrant's oxidative stress profile, which provides an oxidative damage score that can be very motivating for patients who want to slow the impact of oxidative stress on aging. A second cause of excess estrogen is impaired detoxification of estrogen. Estrogen biotransformation is a three-phase process. Phase 1 of estrogen detoxification primarily uses the cytochrome P450 or CYP enzyme system in the liver. This system transforms estrogen into various metabolites, including 2-hydroxy, 4-hydroxy, and 16-alpha-hydroxy. Note that phase 1 detoxification actually activates hormones and toxins, making them more toxic. These activated intermediates can produce reactive oxygen species, which can damage DNA, lipids, and proteins. To prevent damage, it's best for these metabolites to proceed as quickly as possible to phase 2 for further processing, and then as quickly as possible out of the body. In phase 2, enzymes conjugate activated intermediates by attaching polar groups, making them more water-soluble and less biologically active for safer elimination via urine or bile. The main phase 2 conjugation pathways used to remove estrogen from the body are methylation, a process carried out primarily by the catechol O-methyltransferase enzyme, also known as COMT, also glucuronidation, where an estrogen is conjugated with glucuronic acid, and sulfation, a process carried out by sulfyltransferases, particularly estrogen sulfyltransferase, SALT1E1, which increases its water solubility and prevents it from binding to the estrogen receptors, thus reducing its activity. However, this process is reversible, and sulfated estrogen can be converted back into its active form by steroid sulfatase, STS. So after phase 2, conjugated estrogen metabolites are released into the bile, and the bile then enters the digestive system where the metabolites are eliminated, predominantly through the stool, but also through the urine. So let's take a closer look at each of these phases now, starting with phase 1. We can get insights on Kathy's phase 1 liver detoxification pathway by looking at the bottom half of her sex hormones flowchart from her Hormone Zoomer results. We can learn about her phase 1 estrogen metabolism by quantifying how much 16-OHE1, 4-OHE1, and 2-OHE1 Kathy is making via the cytochrome 3A4, cytochrome 1B1, and cytochrome 1A1 enzymes, respectively. And also by looking at the ratios reported in the upper right-hand corner of the estrogen section. Kathy's making 15% of the 16-hydroxy metabolite, which is within the expected range of 14 to 33%. The blue cytochrome 3A4 pathway is considered proliferative, so we want to encourage 16-OHE1 to turn into estriol if you're looking to support bone health. but not so much if your patient suffers from proliferative conditions like heavy periods, clots, fibroids, breast tenderness, or breast fullness. And she's only making 8% of the 4-hydroxy metabolite, which is in the lower end of the range, 8 to 16%. We do want to minimize the pink 1B1 pathway because the 4-hydroxy metabolites can turn into reactive quinones. And if not detoxified, 4-hydroxy-E1 can form DNA adducts, changing the DNA structure and increasing cancer risk. Finally, her level of 2-hydroxy metabolites is 77%, which is slightly above the expected 55 to 75%. In general, we want to dominate the yellow 1A1 pathway because the 2-hydroxy metabolites are anti-carcinogenic and have an inhibitory effect on cell proliferation. Additionally, the 2-hydroxy metabolites are also methylated at a faster rate than the 4-hydroxy metabolites, thus are stabilized quickly and are much more stable on their own. More stable means less oxidative stress within the body. So, Kathy's estrogen detoxification is looking pretty ideal so far. Her phase 1 is going well, and she's favoring the less carcinogenic 2OH pathway. But let's check out her phase 2 metabolites next. We can assess Kathy's phase 2 estrogen metabolism by looking at the methylation activity speed dial in the lower right-hand corner. What we see is that Kathy isn't methylating well. It appears her COMT conjugation pathway is quite sluggish, which is evidence of reduced elimination of estrogen and other toxins that require methylation for excretion. On a related note, diindolylmethane, commonly referred to as DIM, is known for upregulating the 1A1 pathway. In fact, many providers use it to help their patients remove excess estrogen. However, DIM also increases the 1B1 pathway a little bit. Thus, using DIM while methylation activity is impaired may actually shift estrogen metabolism away from the protective 2OH pathway and toward the more dangerous 4OH and 16OH pathways, enhancing estrogen dominant symptoms like PMS, fibroids, and breast tenderness. In fact, this is what happened when Kathy tried DIM to fix her estrogen excess symptoms. Her estradiol went down from 5.41 to 2.19, and her 2-hydroxyestrone increased from 4.68 to 9.02. But her methylation activity, it remained low at 0.09. And since the estrogen couldn't get out of the body via the COMT route, well, it went another way. And her 4OHE1 increased from 0.49, which is in the green, to 1.26, which is in the red. So instead of using DIM to push the 2-hydroxy pathway, helping Kathy remove estrogen via the COMT methylation pathway is a much better choice. So, how can we support methylation? Well, we can do it via foods, supplements, botanicals, and lifestyle. Foods that support methylation includes foods that provide methyl donors or cofactors needed for the methylation cycle and COMT enzyme function, including foods rich in folate like dark leafy greens, asparagus, broccoli, Brussels sprouts, avocado, and beets. Foods rich in other B vitamins, which are cofactors for methylation, including B12 found in animal products, B6 found in bananas, potatoes, and salmon, and riboflavin, B2, found in almonds, mushrooms, yogurt, and eggs. As well as foods rich in choline and betaine, such as eggs, especially the yolks, liver, quinoa, beet, spinach, and wheat germ. Nutraceuticals that support methylation can also be used therapeutically when food alone isn't sufficient or when genetic SNPs like the MTHFR and COMT impair methylation. This includes methyl donors like methylated B12, so methylcobalamin, methylfolate, trimethylglycine, also known as TMG or betaine, and acetylmethionine, also known as SAMe. Also, cofactor and supportive nutrients including B6, B2, magnesium, which is needed for enzymatic activity, including the methylation cycle, phosphatidylcholine, a choline source, and acetylmethionine. Botanical and functional ingredients can also be helpful, including curcumin, which can help reduce inflammation that impairs methylation efficiency, resveratrol, which supports methylation indirectly, and sulforaphane from broccoli sprouts, which helps induce phase 2 enzymes and supports detox, though not directly a methyl donor. Finally, lifestyle factors that support methylation include stress management, as chronic stress depletes SAMe and can also impair methylation. This can be done via techniques like meditation, breathwork, or adaptogens like ashwagandha. Regular sleep, as sleep is necessary for DNA repair and methylation regulation, and toxin avoidance, especially xenoestrogens like BPA and phthalates, and heavy metals which impair methylation pathways. Remember here that Kathy is using conventional beauty products, frequently drinks from plastic water bottles, gets poor sleep, and eats a diet high in processed foods, so we had lots of options for supporting her methylation. On a related note, things that impair methylation include alcohol, which depletes B vitamins, especially B6 and B12, smoking, which lowers methylation activity and increases the need for detox, high sugar and refined carbohydrate diets, which induce oxidative stress and inflammation, and just chronic inflammation or infections, which diverts methylation away from detoxification. Now let's talk about phase 3, elimination via bile, stool, and/or urine. What could possibly be going wrong here? Well, what happens if a patient is constipated? Just like the indigo from your new pair of jeans onto a white couch, toxins and hormones can leach from the colon back into the bloodstream and be sent back to the liver for reprocessing. Thankfully, though, Kathy reports daily bowel movement, so the constipation piece doesn't impact her. However, we did a gut Zoomer stool test, and her results showed high levels of beta-glucuronidase and high levels of beta-glucuronidase-producing bacteria. Reading the report comment, beta-glucuronidase is an enzyme induced by aerobic bacteria. Many toxins, hormones, and drugs are excreted from the body after conjugation to a glucuronide molecule, and beta-glucuronidase enzymes can uncouple these conjugates, freeing those potential carcinogens in the bowel and increasing cancer risk. Now, this is an important concept, so let's walk through the impact of beta-glucuronidase-producing bacteria in more detail using the infographic that's now included on the Gut Zoomer report. Starting in the upper left, we know the liver conjugates, i.e. combines estrogen with glucuronic acid so it can be removed from the body. Looking at the conjugated form in this diagram, the teal half circle is estradiol and the yellow circle is glucuronic acid. Now, ideally, estrogen glucuronide is sent to the gut to be eliminated via the stool. See the intestinal excretion listed at the bottom. However, gut microbes like ruminococcus and clostridium produce beta-glucuronidase, which reverses glucuronidation, returning estrogen to its deconjugated form, separating estrogen from the glucuronic acid-binding protein, increasing the likelihood that estradiol is reabsorbed into the hepatic portal vein and sent back to the liver. Since Kathy has elevated levels of beta-glucuronidase-producing bacteria, part of her problem is she's not fully eliminating all the estrogen she's making. In this case, we need to reduce the bacterial overgrowth in addition to supporting liver detoxification, so she can finally excrete estrogen from her body. Here's a list of foods, supplements, probiotics, and lifestyle strategies that are shown to reduce beta-glucuronidase activity or address its underlying microbial drivers. The first step in correcting dysbiosis is to feed the bacteria you want to see more of. This means feeding commensal bacteria with fiber-rich foods like flax seeds, which also bind estrogens, cruciferous veggies and alliums like leeks, garlic, and onions, along with polyphenol-rich foods like berries and apples. You can also supplement with prebiotics like inulin, phos, and resistant starch from green bananas. Calcium D-glucarate is the most studied nutraceutical shown to lower beta-glucuronidase activity. There are also several probiotic strains, including Lactobacillus acidophilus, Lactobacillus plantarum, Bifidobacterium longum, and Lactobacillus rhamnosus shown to reduce beta-glucuronidase activity and restore gut barrier function. Now, if a killing protocol is indicated and your patient can tolerate it, you can also use antimicrobial botanicals like berberine, oregano oil, and garlic extract to decrease overgrowth. And you can always recommend lifestyle changes like adequate hydration, physical activities to support regular bowel movements, as estrogens and toxins are reabsorbed with slow transit time. If your patient has exposure to or elevated levels of toxins that require glucuronidation, avoiding exposure and increasing support for this pathway can also be helpful. This includes toxins like BPA, triclosan, parabens, phthalates, and volatile organic compounds like the ones found in gasoline. For those who want a copy, the handout on the screen is hyperlinked below the video. The endocrine disruptor section of Kathy's Hormone Zoomer results indicate she has elevated levels of atrazine, butylparaben, glyphosate, BPA, and triglycan. So I did education on common sources of these chemicals, introduced her to the Environmental Working Group's Skin Deep database to find new cosmetic products, and encouraged her to purchase organic versions of the Environmental Working Group's Dirty Dozen, so the 12 fruits and vegetables are most contaminated with pesticides, and she also agreed to ditch the plastic water bottles and use a metal water bottle instead. In addition to potentially overloading liver detox pathways, some endocrine-disrupting chemicals like BPA can also worsen symptoms of estrogen dominance simply because they are xenoestrogens. Xenoestrogens can mimic the effects of estrogen in the body, potentially disrupting normal hormone signaling, as this report comment for BPA explains. In addition to slowing the impact of beta-glucuronidase, we'd also want to support glucuronidation in the liver. The chart on this slide comes from page 55 of Vibrant's Environmental Toxins Guide, which is also hyperlinked below this video. And here's a summary slide you can reference showing all the ways to promote healthy estrogen metabolism. Now it's time to talk about the third cause of estrogen excess, which is inadequate progesterone production. To understand what causes inadequate progesterone, it helps to first review the menstrual cycle. The cycle is regulated by hormones from the brain and ovaries. Briefly, the hypothalamus signals the pituitary to release FSH and LH, which control ovarian activity. In the follicular phase, FSH stimulates one dominant follicle in the ovary to mature and produce estrogen. Rising estrogen builds a uterine lining in preparation for pregnancy. When estrogen peaks, the LH surges and triggers ovulation, the release of an egg into the fallopian tube. After ovulation, the cycle enters the luteal phase. The leftover follicle becomes the corpus luteum, which produces progesterone. Progesterone stabilizes and matures a uterine lining to support implantation. Progesterone also balances and protects against the proliferative effects of estrogen. If pregnancy does not occur, the corpus luteum breaks down, progesterone and estrogen levels drop, and the uterine lining sheds, starting a new cycle. The collection instructions for Vibrant's Hormone Zoomer recommends that cycling women collect during the progesterone peak of the luteal phase. For regular cycles, this corresponds with days 19, 20, or 21 of a 28-day cycle, or about 7 days after ovulation if tracking. Now, if a woman didn't ovulate, thus didn't create a corpus luteum, it's likely she's not producing enough progesterone to balance out the amount of estrogen in her body. And it's the lack of progesterone in relation to estrogen, even if estrogen levels are normal, that can result in symptoms of estrogen excess. Stress is another contributing factor to low progesterone levels. Cortisol, the body's stress hormone, is made from precursors that include progesterone. With an increasing need for cortisol production because of high stress, progesterone levels may decrease, disrupting the balance of estrogen and progesterone in the body. Now, when stress happens before ovulation, it can actually delay ovulation because the body's like, I'm about to be eaten by a lion, probably now is not a good time to get pregnant. However, when stress happens after ovulation, this can result in spotting before menstruation because there's no longer enough progesterone glue to hold the uterine lining together. And as progesterone goes down, that signals it's time to shed the uterine lining. One way to determine if there's inadequate progesterone in relation to estrogen is to look at the beta-pregnenolone to E2 ratio. Looking at Kathy's results, we see that her beta-pregnenolone to E2 ratio is on the low side at 316.7. However, she's making ample amounts of beta-pregnenolone, her level is 1713 when the optimal range is 450 to 1748, so the high end of the range. Thus, she doesn't currently suffer from inadequate progesterone. Instead, it's really her highly elevated estradiol at 5.41 when the range is 0.82 to 1.82 that's throwing off her ratio. However, you can visualize how someone with a normal E2, for example, an E2 of 1.0, but a beta-pregnenolone in the low red, for example, maybe 316, could cause a similar ratio. The other thing worth pointing out is how low Kathy's alpha-pregnenolone is. Looking at the speed dials in the upper right-hand corner, her alpha-pregnenolone is only 141, which is at the very low end of the range, 120 to 500. Beta-pregnenolone is a more abundant urinary progesterone metabolite, and often the only progesterone metabolite tested in urine testing, especially direct-to-consumer testing. In comparison, alpha-pregnenolone converts into allopregnenolone. Allo crosses the blood-brain barrier, is a neurosteroid, and is an agonist at the GABA-A receptor, so it improves sleep and reduces anxiety. Note here that if someone is used to healthy levels of alpha-pregnenolone in the luteal phase, they may really notice it if and when their progesterone drops with an anovulatory cycle or in perimenopause. Poor Kathy isn't making much alpha-pregnenolone, so supporting her progesterone production could help increase her levels. While no foods contain progesterone directly, many support precursor hormone synthesis or improve ovarian and adrenal function. This includes foods rich in vitamin B6 like salmon. B6 is essential for corpus luteum function and progesterone synthesis. Also, magnesium-rich foods like leafy greens, pumpkin seeds, and dark chocolate. Magnesium supports adrenal health and the FSH-LH signaling needed for ovulation. And foods with healthy fats and cholesterol like eggs, especially the yolks, as cholesterol is a precursor to pregnenolone, which becomes progesterone, as well as zinc-rich foods like oysters, since zinc supports ovarian follicle maturation and corpus luteum function, as well as antioxidant-rich foods like berries, beets, pomegranates, carrots, and green tea, since antioxidants reduce oxidative stress that impairs ovulation and luteal phase hormone output. You can also use nutraceuticals to increase progesterone, which includes B6, magnesium, zinc, vitamin C, which improves corpus luteum integrity and progesterone output, as well as myo-inositol, which improves ovulatory cycles and insulin sensitivity, and L-arginine, which increases blood flow to ovaries and the corpus luteum. You can also use botanical support like Vitex, also known as chaste tree berry, which increases LH and modulates prolactin, maca root, which is an adaptogen that supports ovarian hormone balance, and ashwagandha, which supports adrenal progesterone output under stress, as well as the other adaptogen rhodiola, which helps normalize the HPA axis, which indirectly supports luteal function. Finally, lifestyle practices to support progesterone include stress reduction, ovulation support, and sleep optimization. And you can also do progesterone drops to supplement progesterone levels during the luteal phase if indicated. In summary, estrogen dominance is a common condition with symptoms that can severely impact a woman's quality of life. The three main causes are overproduction of estrogen through aromatization of hormone precursors, hindered elimination of estrogen due to impaired detox pathways, and/or inadequate progesterone needed to balance estrogen levels. You can easily identify which cause or causes your patient has by running a urinary hormones test like Vibrant's Hormone Zoomer. When you see elevated estrogen on a Hormone Zoomer, the first step is to ask, is estrogen overproduction present? Check levels of E1 and E2, and identify any contributing factors like adiposity, inflammation, insulin, and stress. If yes, support aromatase modulation and reduce estrogen production through methods such as balancing blood sugar, eating an anti-inflammatory diet, getting adequate daily exercise, and losing weight if indicated. Step 2 is to ask the question, is detoxification or elimination impaired? To do this, check estrogen metabolites, so is there elevated levels of the 4-hydroxy or 16-hydroxy? Is there low levels of the 2-hydroxy metabolites? Also check if a methylation is impaired. And if you run a gut Zoomer stool test, you can also check to see if the patient has elevated beta-glucuronidase levels. If yes, you definitely want to support relevant phases of detoxification, making sure, of course, to upregulate phase 3 before phase 2 and phase 2 before phase 1 so you don't have a blockage and end up with lots of that toxic intermediate. Step 3 is to ask, is there a progesterone deficiency? So checking for low beta-pregnenolone, alpha-pregnenolone, and/or a low beta-pregnenolone to E2 ratio. And also identify any related symptoms like PMS, short luteal phase, anxiety, and sleep issues. And if yes, you'd want to support progesterone production. Finally, craft a targeted plan to address all the imbalances detected. And that's it. Thanks for watching. Please let me know if you have any questions.